So good afternoon, everyone. Thank you very much. And it is a duologue, actually. So it is going to be not one speaker, it's going to be two speakers, and we're just going to make more fun in terms of just discussing and making it answer to the questions.
Just hold on, Suresh. I need to introduce you also at the same time.
Okay.
Suresh is MBBS and MRCP and internal medicine specialist, diabetology and endocrinology specialist. He is from Coimbatore, consultant diabetes and endocrinology at Ramakrishna Hospital, Coimbatore. Over to Suresh and Rishi also.
Thanks for apologies, sir. We didn't know that you haven't completed. So it's going to be a duologue, and we'll just try to make more entertaining by just asking ourselves questions and then try to come up with some answers. So I think it is about unlocking the power of innovation with a new generation of insulin and the need to advance from human insulin. So we have moved in a lot of ways with our practical things in life, like that for the usage of insulin. We have to move on from the human insulin, how we do that and how practically we can think about few options and what are the challenges and what is the evidence available and how to switch over very smoothly. And this is the whole agenda of this program. So we got financial disclosure, and it's Novo sponsoring the talk. So the agenda is going to be about the conventional insulin. So what is available, how it started, and what are the things that has happened over the years. And after that, what are the challenges that the insulins are facing out, why we need to think about the other generation, new generation insulins, and the new generation co-formulation, how it is made with the solubles and rapid acting ones. And the third one is about the new generation of basal insulins, and then the new generation of bolus insulins as well. So this is our agenda. We'll just take it. So the context is about 8 in 10. These are the challenges. These are all the unmet needs that is in the diabetes. So we got 8 out of 10 have got uncontrolled glycemia. And then the 2% will have more A1C. You and me see practically in the clinic. So HbA1c of 10 and other things. So, and insulin initiation is still a challenge. We all know that. And with gliptins and SGLT2s and incretins coming into play, the delay of insulin initiation is extending more and more, and the average is around 8 to 8.8 years, and only 3 out of the 10 being managed with insulin. And there is one data is missing. There are only less percentage of people who are managed properly with insulin. So because a lot of insulins are happening ad hoc, how well it is managed and what are the appropriate insulin for the right guy, that is also a thing that is not done in Indian context. So I'll leave it to Dr. Shukla to start. One more thing, it's just about the injections, 2 injections with NPH, and then a lot of changes after that, and then that came to where there is a less variability. Insulin was discovered with nocturnal hypoglycemia, and the insulin development, as I said, has come long way from animal insulin. I mean, those days we got trained. I think that was the pork insulin is going out of this thing. We're talking about 94, 93, those kind of times. But before we dive in, I just want to ask Dr. Shukla, can we elucidate what are the clinical challenges? So persist with the conventional formulation what we got now, and can you explain to us these challenges, or how we can rectify the challenges as well, but what are the challenges mainly? I leave it to you, sir.
Thank you, Dr. Suresh. A very warm good evening to everyone. Thank you, sir, Dr. Bijmohan, Dr. Kavita, for nice introduction, and thank you, Novo, for the opportunity. Actually, whatever I am going to speak, we are going to talk about new insulin, everybody knows it. But one thing for sure, it is not possible for any new insulin to have existence without the old. So this is the basic thing. And it is more than 102 years. 1923 the insulin came, and now 25 102 years, a lot has happened. So every insulin will be new and every insulin will be old. But we're going to talk whatever is at the moment. The challenges with conventional insulins are variable absorption, slower onset, less predictable action, delayed action, high risk of hypoglycemia, no mealtime. So lot of things are there, but we have been using these insulins. So this is one thing. It's not, we have better insulin, but at one point of time, it was also better. So this is one thing that one has to keep in mind. And the best part with the conventional insulin is that it is a cheaper insulin also. So that thing you have to keep in your mind. With the known limitations of conventional premixed insulin, I think this is the question for you. I can read for myself.
Yes, sir. No, I can do that, sir. So I think you explained it in a way. These are the challenges. Now I'm going to ask a question. With the known limitation, we know that conventional premix have got the challenges, what you mentioned, the less variability, slow onset, and delay in getting action. So how does the evaluation of the co-formulation insulin improved glycemic control, and whether it's safe to use it, and what are the safety outcomes? So I want to know your input on the glycemic variability, the safety outcomes, and other things. So I'll leave it to you, sir.
I think we have moved a long way from mixtures to analogs to co-formulations, and what next? And next is also in the row. We have icodec insulin, we have the combinations of various insulin, we have innate. So a lot has started happening. So with the known limitations of conventional premixed insulin, so we have a basic human mixer, the mixtures, 30-70 mixtures are available. Then analog, the 25-75 or 30-70 analogs. And the third is the co-formulations, the degludec aspartame. By now, only one co-formulation is existing in the market, and this is degludec and aspartame. So the question is, what is difference between premix analog and the co-formulations? I'll not be reading out the thing, but the basic thing is, in co-formulation, in the premix analog, there are two molecules. And in co-formulations, also there are two molecules. But in premix, what happens, there is a one live molecule, that aspartate insulin is the active molecule, whereas the analog is relatively inactive. It works in a subtle way and more or less responsible for the basal control. Co-formulation, both the molecules are active molecule, and these solutions are together in a fixed ratio or a combination. Thank you. And it mimics physiological insulin secretion closely, and no shoulder effect compared to analog insulin, and simplifies the insulin regime without requiring resuspension, and lower the suspension is no longer, you need not shake it, you can use it as such. And if you look at the co-formulation, it has a very nice adjacency reduction, and on your right side, the extreme right is the OAD treated patients, and the left one is the OAD plus insulin. And if you look in both the category, when Rhizodec was used, the fall of A1C was almost equivalent. It works very nicely in fasting and the pre-meal blood sugar control, because it has a very nice basal insulin, and it also works very nicely with the postprandial, because it has an active aspartate component. So whatever meal you are taking, it reduces the post meal. You can take it once, you can take it twice, or you can take it thrice. The safety wise, so far this is the safest mixture, and if you look at the confirmed hypoglycemia compared to baseline, you can observe there is a significant reduction in the confirmed hypoglycemia, whereas on the right side, the severe hypoglycemia, which is a very dreadful. I mean, all of us have experienced severe hypoglycemia through our patients. Patients need somebody's help. They were found unconscious, and more or less most of the time they stop taking nitroinsulin. No, doctor, I don't want to take insulin, because it's better to have uncontrolled diabetes than to have hypoglycemia or severe hypoglycemia. So this is no longer severe hypoglycemia. So this is, I think I remember my 2-3 of very well-read patients, they had nocturnal hypoglycemia, and when I put them on this, they are intelligent. Doctor, you have done wonders. So use this molecule and use this intelligently. And it can be used across all populations, from pediatrics to elderly, to fast, to type 1D, I mean, everywhere, wherever you feel like, to pregnancy, hepatic insults, renal insults. So wherever, whatever is the condition, you can use it. Yes, sir.
Okay. So thank you for explaining that very nicely. So you said that the co-formulation has got its own advantages and there's less hypoglycemia and it's quite safe and quite efficacious. So while we have discussed the efficacy and safety of Rhizodec, that how would you describe the impact on dosing convenience and how it is how it makes a difference? You mentioned 1 or 2 cases of yours, but overall quality of life in managing diabetes, and could you explain on that, please?
The quality of life is what? Life becomes smoother. One thing for sure, whenever our patients use, patient goes into resistance and we go into a lot of persuasion. And when patient starts using it, and fortunately, if patient is switched over from one variety to second or second to third, maybe from mixtures to analog or analog to co-formulation, they can feel the quality. And you can see on your left side, improved quality of life with reduced pricks, found in comfortable to inject Rhizodec, could manage their day-to-day activities. So it matches because you can take it any time of the day. So you have a lot of meal flexibility. And quality of life is, I mean, from baseline and at 26 weeks, you can see that a very nice quality of those for busy workers where meal time is not fixed. They forget. Probably this is one of the best insulin which controls, and the compliance part is also taken care of. So meal flexibility is there. People traveling across time zones, shift workers, and young people, the weekend syndromes. I mean, I was talking to some of the guys outside who are coming, because we'll go to pub tonight, today and tonight pub. So those who are on insulin, so they can modify their insulin, not pub. So this is the way they want to do. So Rhizodec is a pragmatic choice at insulin initiation. Low hypoglycemia, mealtime flexibility, simple regime, better quality of life, not much confusions, and it works very well. The next, I think, next question I'm going to ask from Dr. Suresh. What would you say are the shortcomings of conventional basal? So now we are going to talk about basal insulin. So a word about basal.
Yes.
Over to you.
Thank you very much, sir. And interesting about the pub thing, but yeah, so I didn't see in that this category of people.
Sorry,
but yeah.
I'm crossing those from apologies from the people, but I think it has to come from heart also.
Oh yes, sir. So I'll join the club. Anyway, so what
He
would
was talking actually. He wants to. But
so I'm one of them anyway. So that's why I get the blame always. Thank you for this. And so next 4 or 5 minutes or so, we're just going to concentrate on basal insulin. So thank you for updating our co-formulation, how we switch on from the traditional premix and what are the advantages of co-formulation. Now we're just going for the basal. Now isolation of Banting and Best and to animal insulin preparation. We went through all that, and the NPH is the molecule until now providing the sort of basal cover for human insulin, and detamir is going to be go off phase out, and we still use for a lot of pregnant women, but it's a very good molecule, but it's got its own challenges. And then we got glargine 100 and glargine 300, and then now degludec is also available. So these has moved a long way, and if you look at the half-life of the newer generation thing about glargine U300 and Tresiba, which is the degludec, so we got a really ultra long-acting basal insulin analogs, almost 25 hours of half-life. And then I'll show you some good data, just a couple of slides. It will just demonstrate how the glycemic variability is less, and also the TAR is maintained with this molecule. So this is the molecule that we are going to talk about. Now, this is the unmet needs. We have seen the unmet challenges for the twice daily insulin, but if you look at the challenges for the basal insulin, if you think about the the days of insultod. Now it's not true insulin once daily, 24-hour coverage is not there. And then the variability is there. That is one of the biggest challenges. And then dosing flexibility. We are mentioning about POP guys, but also the type 1s and other guys who needs a bit of flexibility. And then it should be a peakless insulin, which all we like about in view of avoiding hypoglycemia. So I'll just want to say that these are the unmet needs that is there in basal insulin.
Yeah, I think let me share my experience, because I have done endocrinology almost 31 years. 93, 94 I started, so 25, so completed more than 3 decades. So I'm the person who used lente insulin. I'm the person who used NPH insulin. I'm the person who used, when glargine was launched in Philadelphia, I was there. I'm the person who used U300. I'm the person who used other basal insulin. So I think, and when Dr. Damodhar was showing the first slide, I had a very deep respect for the person who evolved insulin.
Absolutely.
From simple insulin to intermediate acting to long-acting insulin, and how it modified his life. Because now we are moving into BMWs and Jaguars,
exactly.
And I think I'll call these like that. So coming to the next question, can you deep dive into how the PK/PD properties of Tresiba contribute to its suitability as a basal insulin in clinical practice? Dr. Damodhar, please.
Yeah, so we are talking about the BMW. For example, if you got a BMW, you need to identify what are the good things about that BMW and how it is different from the other cars. So if you really want that and the high quality insulin, what is the unique features that makes that insulin to be used just like that compared to other things, and that too in the clinical practice. So if you got NPH, as I mentioned earlier, the onset of action is only 2 to 4 hours, and 4 to 12 hours, it has got its, definitely it's got its role, and the duration of action is almost 12 hours. So we need to give it twice daily along with a rapid acting insulin, then it sorts out. So almost like we got 2 of the basal insulin and 3 of the short acting insulin, which makes it 5. Now glargine U100 has made a difference, and it came up with a real this thing when we are all training. We said the training, and I'm also almost in the same troop, but 2 to 4 hours and 8 to 12 hours of peak action, but the 22 to 24 hour action was there with the glargine, and this is the molecule that made us to all start using basal insulin just like that. But the Tresiba, which made a huge impact with the molecule by itself, it is the fastest onset of action, and then it prolongs for a very long time, so with a minimal peak. So peakless insulin is the one I mentioned about the challenges what we wanted for a basal insulin, and this has provided that, and that is why I think in clinical practice, if you look at it, you want to use something like that and just forget, so that the patients will not get any nocturnal hypoglycemia, the variability will less. I'll show you 3 or 4 slides on that. So this is the thing that I was mentioning earlier, the daytime glycemic variability. You see the hours here from 0 to 6, 6 to 12, 12 to 18, and 18 to 24. The variability for all these people who are on that is definitely almost neutral. So you see that. And then when you use the glargine, you see that 18 to 24 hours, there is a slight dip in the variability. This tells you that the total glucose lowering effect distributed of the 24-hour period, it is definitely better with Tresiba as a deglutec as a molecule compared to glargine 100. Because if you see all the clinical trials, is almost comparable or almost compared with glargine U100, because that was the standard molecule for decades. From our training days. So, and then how about the glycemic variability in glucose lowering effect when compared to deglutec versus glargine 100? So you can see clearly the gray ones are glargine 100, and the Tresiba or the deglutec is in the deep blue. So you can see the difference. The variability is more in glargine 100 compared to deglutec molecule. So the total lowering effect distributed within a day, days, the Tresiba as superior. So I given you 2 things. One is the glycemic variability, and then the hypoglycemia. I'll let Dr. Rishi to. handle this.
I think while he was describing, I was imagining we had gear cars. Now we have automatic cars. So we need not apply our brain when to put a next gear and synchronize with the speed. Something similar is take insulin and forget it. And if you forget the time, you can take it any time of the day. Even if you forget the day, you can take it next day. So, I mean, the amount of flexibility is too much. Now I think the another input which I would like to have from Dr. Damodhar is, have these attributes transferred into real world evidence? So over to Dr. Damodhar.
So if you take a BMW, that will be mostly gearless anyway, so it will be automatic. So we got quite a lot of attributes to the molecule by itself. As I mentioned, the fast onset of action, and it's there for a long time, and the variability is less, and the efficacy is more, and the chance of getting less hypoglycemia is more. So these attributes, any evidence is one RCT has to come in, and then the next one is the real world evidence, whether it's proved in our practice. We can all say in our practice it is all there, but when it comes to real world evidence, whether the evidence is available and whether it shows the attributes that we are talking about is translated into clinical practice, the answer is yes. If you look at the efficacy, the baseline 12 months and the change, there is almost like 1.8% A1C change, which means almost like a 60 millimoles or milligram per DL of blood sugar changes. So that is a huge impact when you compared with the molecule. So a significant reduction in A1C and fasting, which is the very, very important thing. I mean, you come up with concepts every now and then saying fixing the fasting first, and the hepatic glucose output has to be addressed and other things. But if you take it, the overall A1C reduction has to be there. And in Asians with the PPG excursions, that with the carbohydrate load, that has to be addressed as well. So the overall A1C is number one, and the fasting will make a huge difference. So if you look at the...
I think just one point I would like to highlight. I think if you look at the baseline 9.6 in 12 months, it was 7.8. So I would always say, give some time. आपको चाहिए एक उम्र असर होने में. So I think there should give some time. Don't run after blood sugar. Don't run. Give some time. Monitor and titrate dose gradually, and don't get panicky. Neither you nor your patients. Yes.
So you mean to say probably not glucose-centric, but there are a lot of things, and don't be just focus on blood sugar in a short time duration.
Then only we'll be able to achieve that.
So we need to be aware of that. But I think when we talk about the molecule efficacy, it is there, definitely proved, and this is the real world evidence. And the superiority of deglutec over glargine 100, this is by TIR. So we are talking about TIR is the scientific way nowadays. When you get a molecule, that excursion should be reliable, or it should be acceptable to provide. You can pass the exam by multiple ways, but the passing the exam in the right way is the one we are talking about. So having less excursion and maintaining the TIR and achieving the A1C will be the right way to do. So estimated treatment difference is significant, and 20 minutes is the variability less. That means the efficacy is super. So we are talking about deglutec comparing with the glargine 100. And how about the hypoglycemia? So efficacy is proven now, and then this is for the real world evidence for hypoglycemia. So when you take the BEGIN trial or SWITCH or DEVOTE, which is more of a cardiovascular outcome trial, and then real world evidence of EU treated type 2, which is done in Europe, but consistently proven hypoglycemia benefit is definitely there. When you take the BEGIN trial, 28%, and then the nocturnal hypoglycemia reduction is 49, and then that will lead to severe hypoglycemia reduction by 86%. Almost all the clinical trials are showing the same. So hypoglycemia benefit of deglutec compared to glargine across all the RCTs, and then I mentioned about the real world evidence which has to be translated in clinical practice, almost 16,000 patients. So we got a safer molecule, we got an efficacy molecule that needs to be taking care of all the attributes that I was mentioning earlier. So, and then flexibility, how about the flexibility? You know that when it started marketed, it's almost every 3-day molecule, and Icodec is planned for a 7-day molecule. But I think this is the molecule initially planned, so that much half-life and almost 40 hours are there, and there is flexibility is very much so, and it is proven beyond doubt with the deglutec. So it can be used with multiple population, and pregnancy, yes, pediatric, yes, adults, yes, adolescent, pub goers, yes, and elderly, yes, and the renal and hepatic, yes, and hospitalized patient. And hospitalized patient is much more convenient. I look after a lot of cardiothoracic patients, so putting on basal insulin like deglutec, it just solves a lot of problem, but you have to explain sometimes the cost and everything to the patient relatives, and they definitely will accept. And that time of post-op period, if you don't get a hypo, and that is the biggest advantage, and they'll eat or they don't eat, and it just varies accordingly. So having a molecule which takes care of that attribute of hypoglycemia is so much advantageous. So hospitalized patient definitely definitely a winner in this aspect. So I would say deglutec as compared to glargine, time to upgrade, and the reason for that is I've just mentioned in the last 4 or 5 slides. So action, it is because of the faster and longer duration of action, and variability is less. I've shown you a couple of data with glycemic variability and also time in range. And then efficacy, it's super efficacious with the A1C reduction and the fasting reduction I've shown you. And then the safety about the hypoglycemia is less, and it proven safety in RCTs and then real world evidence both. And the convenience wise, it is super convenient with flexibility. So I'm going to ask, so we just done the co-formulation number 1, and we have just touched based on the basal insulin. Now I'm going to ask Dr. Rishi about the bolus insulin. Now bolus insulin reimagined the shaping the future from a strong foundation. So we got Novorapid and other molecules in the baseline. Now how we upgrade it and then shaping the future, I'll let you answer this. Thank you.
So we have base short-acting insulins, then analog insulins, and then ultra-short-acting. So 3 category of insulins we had, and the limitations we have already discussed: slow absorption, unpredictable absorption, does not match with meal time, and the chances of hypoglycemia later is also seen. And lot has happened over the decades. I think 10 decades is a huge period. So now we are seeing one of the finest and best insulin. So from basic short-acting insulin to lente to analog. Analog came in India, if I remember, 1992 or 3. And then the aspart insulin and various other analog. If you look the physiology wise, it's not coming. The ultra fast insulin starts functioning little earlier, and it tries to match with the meal spike. So, and it finishes faster. So this is the advantage. So spike, the meal spike is definitely lesser. So aspart and ultra short aspart, both are useful. And again, I would not say that everybody should use ultra short acting. Depending on meal pattern, you have to tailor the dose. Then if you use Fias, the ultra short acting insulin, the area under curve is 70% lesser. So the prandial control is a little better. But what is important, and again I am contradicting the fact that A1C is same in both the categories. So this is a very, very important part. Safety-wise, low risk of delayed hypoglycemia, which is evident that it starts acting faster and finishes faster. So chances of later hypoglycemia are lesser. But if you eat less, the chances of hypoglycemia within 1 hour, 2 hours are a little more. So that one has to keep in the mind. So within 2 hours after meal, 22%, within 2 to 4 hours, 28%, and between 3 to 4 hours, I think. So it is a convenient insulin. You can use it, it functions faster, and it covers the I think, post-meal rise of blood sugar, and useful in patients with erratic eating patterns. So I think this is the comparison of regular human insulin versus Fiasp insulin. So it mimics more with the physiology. I will not be going into detail, and lesser chances of hypoglycemia. And it can be given in, as we have been discussing, in anything. And another part is that is at the right side of bottom is you can use it in the pump also. So pump, this is a very good insulin, because pump we have been using 3 types of insulin: regular insulin, analog insulin, and the Fiasp. The chances of hypoglycemia are lesser with the Fiasp insulin. So to sum up, greater A1C reduction, lower risk of oral nocturnal hypoglycemia, lesser glycemic variability, wider window of dosing flexibility, and improved quality of life, because you can take it anytime, and convenience with pen device. So this is, I think, thank you so much.